I'm better with person-to-person stuff, not technology stuff. All right, we're recording. Just make sure, at least, if you can just give me feedback. Can you see the presentation there?
Yes, I can see that.
Perfect. Okay. Awesome, guys. Well, thanks for bearing with me for that 10 minutes or so. But really happy to have you here. This is a little bit awkward for me because I can't see anybody. So I feel like I'm just talking into a presentation. So feel free along the way. If you have questions, leave them in the chat part, or if you just want to talk through your mic, you can definitely do that as well. But we're going to jump right into it so we stay on time. So tonight we're going to be running through chronic lower back pain, what you need to know, creating your comeback story and getting back to your best. Let's see who's coming on through here. It's all good. Perfect. So for those who I haven't met, my name's Dan. I'm the owner of Scope Sports Injury and Exercise Clinic, proud husband to Claudia there, and my two kids, Hannah and Benny, with a third on the way in the next month or so. So we're counting down the days. I'm a sports chiro strength and conditioning coach and a previous chronic lower back pain sufferer. And that's a big part of my motivation for helping people with back pain is because I've been through the challenges of being the person with back pain as well. So we'll talk more about that in a moment. But tonight, what we're going to cover, we're going to talk about in the first part, what does the science say? So we're going to talk a little bit about the current understandings of back pain. What are the general guidelines? What are the things we should know and we need to know? Also, what are the misconceptions and myths that are just around? And there are a lot of them. Part two is about creating your comeback story. So this is more about an evidence-based approach and a practical approach to resolving your lower back pain. So these are the things that I talk about with patients on a day-to-day basis and the things that I truly believe need to be understood to make a really solid recovery as well. Part three is we're going to get moving. So we're going to run you through a bit of a mobility flow that I like to utilize in the clinic as well. And then the last part will be our Q&A. So if you do have questions along the way, pop them in the little chat box. I'll check them every now and then, and Elise will yell them out to me. So if you have questions, let me know. Otherwise, if they're more in-depth questions, just save them for the end of the presentation and we'll spend time there. So a quick brief on my background. So back in about 2013, I injured myself CrossFitting. I was doing a clean, and I ended up having about 4 or so years of persistent back pain. It would just kind of flare up, last a couple of weeks, slowly go away, and I just ended up in this kind of chronic cycle of back pain. And over that time, I saw a lot of people. I was a chiro at that time as well. I was a first-year chiro, so it was quite an interesting, perspective, I guess, being a practitioner plus having the back pain, the thing that I was supposedly meant to be treating. Let's say that person in. And my experience was that, which is unfortunately quite a common experience. I went to lots of different practitioners. I saw chiros and physios and EPs and massage therapists and doctors, and I was sent for lots of scans. I was offered injections. I was offered potential surgery at one point. And I was getting all these mixed messages from everybody. It was really confusing. I was getting very down on myself as a chiro as well, thinking, how do I help people like myself? If I can't help myself, how am I meant to help other people? It was really kind of challenging time for me. But through that process, ultimately, I was really felt to be vulnerable. I felt like I was weak. I was told not to do a lot of things. I was told that every time my back flares up, it's going to maybe be one step closer to surgery. It was a lot of negativity around it and very little positivity. Most of the treatment that I got from people was really around the short term. So it did help me, some dry needling and some general stretches and mobility work. And it does help in the short term, but no one really guided me back to full recovery. Until I met somebody just by coincidence who ran a kettlebell gym down in Brisbane. And he was a strength coach. He had no history, no knowledge or understanding on back pain or any of those kind of conditions. But what he said to me was, why don't you just come work with me for about 6 months? We're going to work on all the foundations, all the basics. We're just going to learn to hinge and squat and carry and all these real basic movements. He said, just commit to me for 6 months and we'll work together and we'll see where you're at the end of it. So at that point, I said, absolutely. No one else has really spoken to me like that or given me a plan of attack like that. And lo and behold, that's four to 6 months later, I was literally feeling stronger than I was before I injured myself. I was swinging heavy kettlebells, which, as most people know, is a pretty back-heavy exercise. I was lifting solid, doing solid deadlifts, but ultimately, it was just I was completely confident in my back, and have been ultimately ever since. So that's my story, and I think about that regularly because I see lots of patients who go through the same challenges that I'm going through, or that I went through, sorry, and I don't want them to go through that. We want to have a bigger impact on people dealing with chronic lower back pain. So that's where my passion for all this stuff kind of comes from. And tonight I'm going to shed a fair bit of light on both the evidence side of things, but also just from an experience side of things. What are the important things you need to know? What are the really big things that the big rocks that are essential to know to make a long-term recovery? I'm assuming everybody here is dealing with back pain, or maybe knows somebody who's dealing with back pain. So hopefully this resonates. If you know somebody, please feel free to pass this presentation on once we're finished up. Is everybody still there? Elise?
Yes, all good. We can hear you.
Perfect. Okay. That said, I feel awkward just staring into a computer and talking to it. So we're going to start with common myths and misconceptions. This is a research article that was published in the British Journal of Sports Medicine that basically went through and looked at the top 10 misconceptions out in the public around back pain. So I'm going to briefly go through these, and I'm sure some of you will, a few of these will take you by surprise. A few of these will maybe challenge your current understanding of your own back pain or what you believe to be back pain. But I promise you, as we go through the presentation, we're going to lay some good foundations and maybe recalibrate how you think about this stuff. So number one, persistent pain can be scary, but it's rarely dangerous. That's a really important one to know, because a lot of the time, the longer the pain's around, the more vulnerable we feel. Often, the more the more danger we might feel we're in. I know that I was told that if I keep feeling my back up, I'm going to end up possibly in surgery. We've had lots of patients come along say, are they going to end up in a wheelchair? Things along those lines. It's a really tiny percentage of people with back pain who actually end up with very severe symptoms, and it's usually not to do with structural things. It's usually a separate kind of disease, but it's under about 2% of back pain sufferers. Number two, getting older is not a cause of back pain. Another big one, we often just put it down to age. We'll talk more about this in the coming slides, but ultimately back pain and age are not as correlated as we once thought. Persistent back pain is rarely associated with serious tissue damage. That's a very big one. When we have a lot of pain in our back, we might think that there's a big injury, but more often than not, there actually isn't a big injury. It's more just the inflammatory response that we're going through. Number four, scans rarely show the cause of back pain. Again, the big one, lots of people want to go to images very quickly, in particular in the allied health field and the medical field, but it's actually not a recommendation in the guidelines, which we'll talk about shortly. We don't need to jump to MRIs, X-rays, CT scans and the like too quickly. In fact, usually we actually want to wait and see if there's other signs before we send for a scan, because that can lead to negative long-term outcomes. Number five, pain with exercise and movement doesn't mean you're doing harm. So sore but safe is a nice motto we sometimes use in the clinic. But pain, the other one is pain does not equal damage. Just because we feel pain doesn't mean that there's some kind of structural damage occurring. And I'll put that in more perspective shortly. Number six, back pain is not caused by poor posture. A big one as well. A lot of people think back pain and posture are correlated. There is not a strong correlation there. It's typically the lack of movement that's the bigger correlator there. It's not the actual posture itself. We know people can have really bad posture and actually not have any back pain. And on the flip side, we know people can hold really quote unquote good posture and have back pain. So the correlation between posture and pain is not quite there. Back pain is not caused by a weak core. And this, we can also throw glutes into that as well. Again, another common misconception on back pain. Weak core is not really an easy thing to define, and it's different for everybody, but there's no real great studies out there that can put those two things together. Number 8, backs do not wear out with everyday loading and bending. So often there's a lot of fear around bending the spine that can be quite bad for us. Even in workplace environments where people have to lift as part of their job, the general recommendation is to bend from your knees. And that's actually changed a fair bit from a research perspective over the last decade, where we're starting to find, hey, you know what, maybe it's okay to bend from your spine. It's not such a bad thing. So there's a big one around bending from the spine and lifting from the spine. But our body is very strong and very resilient, and it is something that we can actually do. Pain flare-ups don't mean you're damaging yourself. Number 9, again, coming back to our sore but safe, or pain doesn't equal damage. We know pain flare-ups happen, and they are painful, they're uncomfortable, but it doesn't mean that there's a bigger injury underlying that. And lastly, injections, surgeries, and strong drugs usually aren't a cure. We'll talk about the guidelines shortly, but one of those big ones ultimately is someone trying to enter. There we go. So one of those big ones again is that medication, drug, they're not a first-line treatment, and I'll show you a little bit on that in a second. Okay. So why do these things exist? And this is probably the sad part from a clinician or a doctor point of view, is that these actually come, these beliefs, according to this study anyway, there's a few like it, actually come from their health professionals. So you can see here in the results section, most participants indicated that they learned these negative beliefs from health professionals. And that's obviously quite sad. This study is not such an old study. I think it's about a 2017 study, if I recall. And that's actually where a lot of it comes from. There's still a lot of poor messages that come from doctors and chiros and physios and anybody who deals in the back pain realm. There's still a lot of the wrong messages coming out there. And this is what I believe to be part of why so many people really struggle. They get a lot of poor advice, poor education, and ultimately end up making poor decisions on how to manage their back pain. This paper here, a fascinating one as well, looked at how the different words we use can lead people down different treatment pathways. So the conclusion from here was different terminology given for the same condition influence management preferences, psychological outcomes, and a consistent pattern in these studies. What they actually went through in that study, which was fascinating, is we could have the same diagnosis and use different words to describe that diagnosis. So, for example, degenerative spine disease. If we use that, people were more likely to feel like they were less in control of their back pain. They were more likely to have things like injections, medications, and surgeries. But if we use different words, things like age-related changes or just normal wear and tear, just put these in the context of this is just normal change, people were more likely to feel like they were more in control of their symptoms. They were going to take more proactive approaches to improving their condition, and they were more likely to go down more of a conservative management route. So really, really important, that one, that if you are working with a clinician or a doctor, you know, thinking about the words that are coming out their mouth and even asking how they might reframe that, if asking if things are normal, asking if these kind of things are can be managed conservatively, is really, really important, because we see almost daily now in the clinic people who have unfortunately not been offered conservative care, and conservative care meaning exercise, rehab, hands-on therapies, things like that, to help manage and resolve their symptoms, and they go straight down the medication, injection, sometimes surgery pathway when it wasn't necessary. Of course, there are times where it is, but for the vast majority, it's not. I'm going to come back to that slide in a second. So we're going to go back a few slides. I wanted to touch on the current recommendations off the back of that. So these are our current clinical guidelines. Denmark, UK, and US, and Australia follow suit. So we can see on the left-hand side, acute lower back pain less than 6 weeks. Our first-line treatment is advice to stay active and education. Our second-line treatment can be spinal manipulation, massage, or acupuncture. These are like our hands-on ancillary types of treatments. And if the treatments above fail, NSAIDs or anti-inflammatory medication is an option as well. So that's your first line, second line, and third line. Now, chronic lower back pain gets a little bit different. The first line treatment for chronic lower back pain is to stay active around patient education, exercise therapy, and cognitive behavioral therapy. So these are very proactive approaches. It doesn't say anything about treatment in there. It doesn't say anything about any invasive type of treatment. It is about good education. It's about exercise, rehabilitation. It's about staying moving. Our second line treatment comes into the same as the for the acute back pain, which is spinal manipulation, massage, acupuncture. But then again, we go down yoga, mindfulness-based stress reduction, and interdisciplinary rehabilitation. And then only if all else fails, do we go down the anti-inflammatory medications and other more hardcore drugs and potentially surgery. But that's really, you really have to kind of give these things a really solid whack. And ultimately, it's not just a couple of weeks or a couple of months working on these things. It's about sticking with them for a good period of time. But really important, first line treatments, if you are somebody who is dealing with back pain, and the first thing that is advised for you to do is take anti-inflammatories, injections, other drugs, surgery. That is not an evidence-based approach to recovery. Our first line treatments are primarily about activity and exercise and education, with second line being our treatments. Any questions on that, just yell them out or pop them in the on the chat box there. So coming back now, from a back pain perspective, back pain, this is from a very, very big study that was done in 2018 called the Lancet series on back pain. Fascinating study. For any of the clinicians or coaches or practitioners on the call, if you want to just message me, I'll send it through you. Anybody who's working with people with back pain should be reading this and basing their treatments and their advice off of this. But the one I just wanted to highlight here is low back pain is complex. It's not a simple condition. And for most of us on this call, we'd probably realize that because things have been around for a little while. But there are more factors than just mechanical factors. There are psychological factors, there's social factors, there's other comorbidities, other health issues. And the vast majority of people with low back pain, it is currently not possible to accurately identify the specific nociceptive, which means pain, source. So that's a really interesting one. We know that for the vast majority of people, we can't exactly say the tissue that is causing it, whether it's a disc or a joint or a muscle or things along those lines. What we do know is that it is a general experience. We know that something in there is just not happy. It's not always one thing. Other things that impact our ability to recover from back pain: smoking, obesity, low levels of physical activity, and the things that generally relate to poor general health play a role. So this we'll talk about later when we create our comeback story. These are things where we have to look at our overall health and not just think it's a stretch that will fix it or a strengthening exercise that will fix it, that we have to actually look at our sleep, and we have to look at how we manage stress, and we have to look at all these other health related things, how much alcohol we're having, smoking, drugs, things along those lines. So really, really important. This paper puts a lot of perspective around our current understanding. And this is a worldwide issue as well. It's not just it's not just an Australian thing or a local thing. It's actually worldwide in most Western countries, and it's probably more of a reflection of our general health than it is of anything else. Okay, so let's come back to imaging. So imaging, what's normal, and is it useful for chronic pain? The research is pretty clear on this, that imaging for most people when pain has been around for a while is not useful, because as we said before, we can't always put it down to a single cause. We might see a disc bulge, for example, on an MRI, but we still don't know if that is a cause of pain. And the reason we don't know that is because disc bulges are actually normal. This study in the top left here had of 1,211 people aged between 20 and 70, 87% of people had disc bulges. Another review had 3,110 participants. 37% to 96% had disc degeneration. And this goes for other areas as well. We've got rotator cuff tears, a common thing. Osteoarthritis in knees and joints and things along those lines. They're very common. So even though we might find stuff on an MRI, we still don't, or any scan, we still don't actually know, because it is quite normal. You could have had that prior and the pain might have just come about. Historically, we believe, we're not sure if most things are incidental findings. So we kind of look at things and go, well, we don't know actually still what is going on here. There are certain cases that we do know, but in vast majority, it's still a very gray area. So when it comes to chronic back pain, those images just are not as important. And it is important that, in my opinion, that anybody who does get a scan needs to ask the questions to their doctor or their clinician about, what is normal for this particular diagnosis. Is this a normal thing? Just like when we get our blood tests, we get a range of what's normal. It's my belief that we should be giving people a range of what's normal for disc bulging and degeneration and things along those lines. So image is not as important as what we once thought. This is another study we looked at that looked at disc degenerations, changes in the bones, which is this stuff, disc bulges, and the percentages are just quite large. Like you're 43, 42%, 57%. It's less as people are younger and more as people get older. So there is a degree of normal related kind of changes. But ultimately, again, it leaves us a bit gray with the images, which isn't a bad thing. It's okay if we found a bulge disc, for example, or some wear and tear in the lower back. If we know that it's normal and there are people out there who do not have any symptoms and have these things, we know that we can get out of pain regardless of what the findings said on the image. That brings us to the next common question that I get. If we do take an image of people, does that predict anything down the track? This is a common question I get in the clinic. I'm sure a lot of the clinicians would as well. So this was a really interesting study where they did a follow-up, a 7-year follow-up, to see if images on people at when they first imaged them versus 7 years, what actually happened. And it says just here, evidence is insufficient to know whether MRI findings can be used to predict the future onset. For me, this hit home because I was told multiple times with my back that when they looked at the scans that, it's going to get worse and it's going to get worse. And, there's not much you can do here. It says, secondly, importantly, no evidence exists that imaging improves patient outcomes. So again, there's nothing to say that there's going to be a better outcome just because we had an image. And the guidelines consistently recommend against the routine use of images for people with lower back pain. So another big study that came out not too long ago, again, just saying images are just not that important. What we see on those images, we cannot predict what is going to happen down the track. If you dig into the paper, it's very interesting. They find people with no back pain ended up with back pain, but their images were actually no different. And we had people with back pain who ended up with no back pain who, again, had better images or no meaningful change. So there's more to it than just the image. So coming back to our guidelines here, this is, again, that summary from that big Lancet paper. Low back pain is a major global issue. Most red flags have limited diagnostic imaging accuracy. Imaging use is often inappropriate for non-specific low back pain. So that's the majority of back pain. Again, another big recommendation to say we don't necessarily need imaging. Advice and activity should be first-line options in the treatment for non-specific lower back pain. Opioids have only a small effect, but have substantial risk. Psychosocial factors are important contributors. So that's our psychological state and things along those lines. And a systems approach to lower back pain involving clinical pathway design is important. So we're going to talk about that shortly. So the big one that I like out here was the advocate the concept of positive health for lower back pain, the ability to adapt and to self-manage in the face of social, physical, and emotional challenges. And that's something that I'm very, very passionate about, helping people to have a positive experience with pain and a positive experience through their recovery process. Okay, so I think people can just join that. All right, everyone happy? We're all doing well? No questions just yet on the chat, Elise?
No questions at the moment.
Perfect. If everyone does, just pop them in there. So a positive, proactive, and supportive approach is needed to resolve chronic lower back pain. This is my personal opinion here. Exercise, rehab, and active approaches to care need to be at the core of everybody's recovery journey. And reliance on treatments, drugs, injections, and other invasive procedure has little to no evidence for long-term resolution and only recommended in a small percentage of people. So taking that proactive approach is absolutely essential. So that's the end of the current research evidence side of things. So if there are any questions, just yell them out now. Otherwise, we'll be moving into the second part. Cool. Okay, so all good. So an evidence-based approach to long-term back recovery. So I love these little memes, I think they're called memes, that pop up on my socials quite often, because I remember feeling this way when I was dealing with my back pain. And this left one here, this is a tale of the blind man and the elephant, but it's just reconstructed to people with back pain. You got one clinician saying he's got an upslip on the right, so he's got some pelvic tilt. You got another one saying it's his foot pronation. You got another one saying it's a motor control issue. It's another one saying it's just tight fascia, tight muscles. And then you got another one that says it's his brain. And you know, this poor person in the middle is just sitting there thinking he's got 10 different problems and everyone's got the solution and there's one thing. And unfortunately, it leaves people in a very confused state. That was definitely my experience, and I know many of my patients as well. This one on the left, I love as well. You've got people with back pain and they've got, you know, they're sleep deprived and they've got anxiety and they're scared of moving and they're not exercising much, and there's all these other issues. And then you go to a practitioner and say, oh, it's because you got a little bit of a leg length difference. It always makes me laugh, this one, because that is unfortunately often what happens. We have people with these ongoing issues that we really got to take a big proactive approach for, you know, and some clinician or doctor has this magic solution, which is this simple, you know, simple, tiny little thing that they managed to find and everybody else missed. But the chances are it's just nothing. It doesn't actually matter. So when we're making our comeback story, where do we start? What are the steps we need to take? What are the kind of big foundations that I believe people need to think about and need to be addressed from a clinician's point of view? So for me, I think it's a lot about starting by reconceptualizing what we believe is causing that pain. Sometimes how we see the problem is the problem, right? If we see the problem as like an alignment issue and we're always chasing manipulation and adjustment to fit that alignment issue, the problem has to start with us changing our perspective on what the issue actually is. If we believe it's a weak core and we're constantly doing planks and core stuff and nothing's getting better, we need to start by reconceptualizing what is the actual issue here, what's causing it. Because if we don't and we keep looking at the issue through the same lens, we're going to keep going down the wrong rabbit hole for finding a solution. So we need to reconceptualize pain, what it is, which we're going to talk about shortly. We need to address the low-hanging fruit. Are we actually sleeping enough? Are we getting enough general movement? Are we getting enough exercise? Are we coping and managing well with stress, anxiety, depression? These things have a very, very big impact on our experience with pain. So we got to sometimes just take a bit of a broader view on these things and say, hey, what does our general health look like at this point in time? The third is we got to understand some key principles of rehab, which we're going to talk about. We need to, and most of these things just make sense. They're more or less the same as fitness. It's a matter of just consistency and progressively building up strength and progressively overloading over a period of time. But we'll talk a little bit more about that in a second. And then fourth, we do need a structure, right? We call it at our clinic a success strategy. We need to have a bit of a structure, a little bit of a plan of action to know where we're going and obviously what's coming up next. So we're going to talk a little bit about pain to begin with, because I think this is an area that most people don't think about, and I think sometimes the belief around pain is not correct or needs a bit of tuning. So what pain actually is, it is an alarm system. It just perceives threat. So it's not a good indicator of damage. Sorry, not meant to say pain. It is a good indicator of pain, but it's not a good indicator of damage, especially when pain has been around for a little while. We can think of it almost like a car alarm. So our car alarm on a brand new car where the alarm is perfect, it's all good, it will only go off if you knock the car hard enough. It's not going to go off with a light gust of air. But when we have chronic pain, that alarm system becomes quite heightened and quite sensitive. So now all of a sudden that alarm is going off as someone walks across the road, or the wind is a little bit too gusty. It's going off unnecessary. And what happens? Well, we start to not know when it's actually a real threat or not. And this is what people experience with persistent pain. It's a heightened awareness of the system, and so we're going to get a lot of false findings out of that. And that's why we can start to say, well, pain maybe isn't always associated with damage. Maybe it's this nervous system that's been very, very sensitized over a period of time. And the way we actually reduce that sensitization is through gradual exposure to movements, exercise, and tasks that you're fearful of, or that you find painful. Sometimes we actually have to go into that zone a little bit, just like any fear. If we want to get over a fear of heights, we actually probably need to start kind of getting used to a little bit of height, just even if it's just stepping off a meter high or something like that. We need to progressively expose our body to it in a way that it can adapt to it and get used to it. And then we just keep working our way up that ladder. So coming back to the previous, what I mentioned in the previous section, there's other factors to pain. We've got biophysics, these are just movement factors. We've got biomechanical factors. We've got comorbidities. We might have other conditions or health issues that might relate to or increase that perception of pain. We've got social factors. That's a really, really big one. So we know that family or social related stresses actually increases our perception of pain. We've got psychological factors. These are the things like our beliefs and attitudes about our stress, anxiety, things like that. They play a very large role. And then there are certain genetic factors. But we need to understand that there's lots of things coming into this. It's not simply just a matter of a tight muscle or a stiff joint or a disc or whatever it might be. That's why we can fluctuate through pain. Because if we're going through a stressful period at work and we're not sleeping so well, then there's no real big surprises that pain might be a little bit worse during that period. It's not that anything got worse. It's just the body is going through a lot at the moment and is trying to just keep up with everything. And we might get increased pain from that. So there's lots of different components to pain there. This is a great analogy from Greg Lehman, who's a very well-known, he's a chiro and a physio and a researcher. And he talks about what's in our cup. So our cup can be anything that creates stress to us. It can be physical stress. It can be how we move and the repetition at work, for example. It could be training, exercising, but it's also things like poor sleep. It's about anxiety. It's about stresses and other things like that. And the more we have in that cup, the closer we get to spill over and where we might have like a flare up. And we've got a few options here. We can either start to reduce the cup, the water going into that cup, by reducing some of the stresses, the things that are actually in our control, or vice versa. The other thing we can do is we can increase the size of the cup, right? So we can start to build a bit of a stronger, more resilient body. And so the body can cope better. We can start to deal with more strategies around our stress and anxiety, depression, things along those lines. Basically, we're not dealing now with the stress so much, but we're dealing with increasing our ability to deal and tolerate the things that are going on in our lives. Obviously, in the clinical settings, we focus a lot on the movement and the exercise and things along those lines. But there's other health professionals, of course, that can help improve our ability to cope with certain stresses in our life as well. Psychologists, of course, are what's coming to mind there. So we've spoken about the pain being an alarm system. It is multifactorial. There's lots of things that kind of can influence it and contribute to it. This is one of the concepts that I speak to almost all my patients about, which is tissue tolerance. So we see on the left-hand side here, we've got this mountain that we've got before injury. So before injury, our tissues could tolerate this amount of stress before injury. Our pain protection comes in a little bit earlier. So what that means is we often will get pain as a protective mechanism to stop us getting to a point where we actually damage tissues. So our brain is very, very smart. It will give us pain. It will stop us doing the thing we're doing before we actually get to a point of injury. Once we've had an injury, though, the issue we find is that our tissue tolerance becomes less and the pain protection increases significantly as well. So now we start to feel that pain a lot earlier as that protective role. But now it's hypersensitized. Again, it's giving us these, it's giving us this perception of damage and issues well before it actually should. And it's mainly about tolerance. And we can change that. That's adaptable. We can actually change that through movement, exercise, and the things we're going to talk about in a moment. But if you're having a difficult time kind of conceptualizing what's going on, think of this graphic. It's a really fantastic graphic, and to me it really highlights the main issues here. I know when I was going through my back, for example, my ability to hinge, like deadlift and kettlebell swing, just went down significantly, like to the point where even lifting something up off a rack, so lifting it up only a little bit, was really diminished. You know, and I had learned this concept around that time as well, and it helped me kind of mentally just go, you know what, it's actually okay. I know I'm feeling it, it's painful, it's not that comfortable, but it's actually okay. A little bit by little bit, got better and better, and eventually it was all good. But one of my favorite little graphics, that one. So what comes out of these experiences for a lot of people is something called kinesiophobia, which is fear of movement. This is one of the other things that we currently think in the research, we currently think is the connection between acute pain, so that the initial injury that we may have had, and chronic pain. So if we develop some kind of fear of movement, and we, let's say bending forward, which is a really common one, and we stop bending forward because we're fearful of re-injuring ourselves and because there's pain, we actually decondition our body to it, and we end up in a more deconditioned way, which actually means we're actually more susceptible to injury again. So kinesiophobia is the actual sciencey term that we use, which means fear of movement. And these are our little 5 steps to help people with that. So the first thing is we need to understand that the body is strong and resilient, and it's adaptable. That's the big one. The second thing is we need to know that pain is not indicative of damage. We spoke about that. The third is to start experiment with moving into positions you're fearful of on a daily basis. So that's that little bit of exposure we spoke about. So moving into the pain just a little bit. Once we've got over the initial kind of fear of just bending the spine, we might start to strengthen it. So we might start to add some weight to it. We might start to explore exercises that involve bending of the spine. And then finally, we want to include that into our general training routine, so it becomes not only a thing of the past, but it actually becomes hopefully a strong point of our body as well. Okay, so that little section is just around the pain and some of those basic concepts. The next thing is our low-hanging fruit. So this is, to me, this is very important, not just from a back pain perspective, but from a health perspective. So we're going to start with sleep, because that's one of the biggest ones. In Australia, our recommendations are 8 hours of sleep. And we should be waking up in the morning, and plus or minus, there are differences, but generally around the 8-hour mark. And we can measure our quality of sleep actually by how we wake up in the morning. If we're waking up in the morning and we're very groggy and tired and we could do with another hour or 2, it's probably pretty low quality sleep, or low quantity potentially. You know, if we're waking up in the morning and we jump out of bed, got our energy, we're ready to go, you know, we're probably getting pretty good quality sleep. It's going to change at different times in our life. Obviously, when having kids and things along those lines, work will impact it as well, people who do night shifts and things. So it varies, but ultimately, if you're waking up in the morning and you're feeling fresh, you're in a good place. If you're not, we need to address things like your sleep quality and your sleep routines, your sleep hygiene. I'll be emailing out our little 5 steps to better sleep after this presentation for you guys as well. Then we come into exercise. Are we getting enough there? And now, obviously, pain can be a very big limiter for exercise. But we need to know that there are lots of ways we can stay active. Swimming, walking, anything that really the back is okay with, we should be trying to continue to be involved with. We need to try keep doing things that are important to us and important to our overall health. So the recommendations in Australia, again, actually these are the World Health Organization recommendations, is to try and get about 2.5 to 5 hours of moderate activity, or 1.25 to 2.5 hours of vigorous activity, or an equivalent of both per week. And we want to try strength train at least 2 days per week. So if we've got back issues, there's still a lot of other exercise, a lot of other things we can do to stay moving and stay active, especially in the strength side of things. We know with back pain, we can find things. If it's upper body training, we're still getting that strength hit. We're still maintaining muscle mass. We're still doing all those healthy things that are essential to keep our system healthy. Alcohol, smoking, and drugs. Obviously, are we working on reducing consumption? Smoking should be nil. Recreational drugs should be nil. Alcohol, the recommendation is under 10 standard drinks a week. To me, that's quite high. But again, like if you're in excess of that, trying to bring that down within those recommendations. And then finally, stress, anxiety, and depression. Are we actively working on improving these issues? So this is, I always recommend psychologists, people who can help you with strategies to help with these things. They're not easy, they're challenging, but they are very important that we do have strategies to help manage them. So that's our low-hanging fruit. So we've reconceptualized pain, we've spoken about our general health and trying to work towards being generally healthier. So now we're going to talk about a couple important concepts around rehab. So the first most important concept here is what we call progressive overload. And a nice story to highlight this process is the story of Milo from Croton. So he famously carried a bull quite a long way. I can't remember how far he went, but when I was doing my research on him, he was a very well-established wrestler, I guess, through the Olympics and things like that back then. But what he did to do that is he actually picked the calf up and carried the calf every day. And every single day, obviously, the calf grew and got a little bit bigger, and his body now had to adapt to that extra weight. And eventually, the calf became a bull. And he was able to actually carry this thing however heavy it was. And that's what progressive overload is. It's just a little bit more each day, week, session. It's just progressively challenging the body just a little bit more each time, and the body adapts accordingly. And you can see just the size of Milo here. He, skinny guy here, pretty solid guy over there. I mean, it's a graphic, but you get the point. The body will adapt in little steps as we just slowly, progressively overload. And that's what we aim to do in the rehab space. Give you, wherever you are at your starting point, find the thing you can do, find the hardest thing you can do well, and slowly challenge you a little bit more so you become a little bit stronger, a little bit more resilient. So that's progressive overload. We can see it just in this graph over here. Very simple. We do some exercise, there's some fatigue, the body adapts just a little bit more. And then we do exercise again, and guess what? It adapts just a little bit more again. And you can see this at the peak of each of these lines here. We can see the progressiveness of our ability to get a little bit stronger every time. Okay. So the second concept is this envelope of function, really, really important. Envelope of function is a famous concept in the injury world, which was by an author named Dye a little while ago, about 20 odd years ago. And he just spoke about the fact that when if we don't do any stimulus, no load or no frequency, there's minimal to no adaptation. We're underloaded. In fact, we're probably deconditioning at that point. Our zone of homeostasis is just an area where we're just staying as is. So some kind of load, some kind of frequency of exercise, and not enough to decondition us, not enough to progress us and make us a little bit stronger and fitter. Where we kind of want to be is in this overload and adapt stage, where we are challenging the body just beyond what its comfort zone is, and that's where it actually starts to adapt and respond really well. And then if we go beyond that, excessive loading, that's where we get to our zone of structural failure. So that's where injury and pain comes in. So if we lift way too much weight, for example, or we train way too frequently, our body can't, we go past the adaptation phase and into the excessive phase, and that's where injuries might occur. So when it comes to the rehab side of things, we don't want to do too much too soon. We don't want to do too little for too often. We kind of want to find this happy medium over here where it's challenging but achievable.
Awesome. Just before you go on, Daniel, there's a question Joe's asked regarding sleep. Would you like to answer that now, or?
Yeah, sure. Can you read out the question for me?
So, question regarding sleep. I slept great before my back pain. Now I've been waking almost hourly from 1 a.m. and usually just give up trying by 4 a.m. Any tips on how to help sleep while the back pain is present to stop the cycle of bad quality sleep contributing to back pain?
Yeah, definitely. It's a challenge, and I was actually meant to touch on that as well. So thanks for the question. It's a great question. That is one of the challenges going through the recovery process, is that the pain in itself starts to impact our ability to stay healthy, right? Our pain, if I come back to it, impacts our sleep. It can impact our exercise and our movement. It can actually lead to us taking drugs and smoking and using alcohol. And it can obviously lead to stress, anxiety, depression as well. Pain whether it's back pain or not is actually, orthopedic injury is actually one of the leading causes of obesity, right? So people, get some kind of injury, get some kind of pain, and that's what leads them into a pretty negative health state. So coming back to the question from a sleep perspective, there are a few strategies, but it is quite dependent on the person, and we sometimes have to use a bit of a trial and error process to figure out what works. A few things that I've found people helps people. Number one, having a sleep routine that involves some kind of light, easy movement before bed. So we actually get a bit of blood through the system. We actually kind of get some motion through the joints and things along those lines before they don't move for 6 to 8 hours. So having a little bit of a movement routine, which is again something that will come through in the post after this talk. So having a little bit of a movement routine is a big one. Also, same thing at nighttime. If you are really uncomfortable, and it is hard, I did this for a little while. Getting up and just moving the back instead of kind of rolling and turning too often. Trying to get up and run through a little bit of movement in the middle of the night, as frustrating as that can be when we're tired and shattered and things like that. Sometimes that actually cools the system down. Heat packs can be a good option during the night as well. Just to kind of override those symptoms. And this is one of those rare occasions that I might recommend someone trial some medication, like a pain paracetamol or something light, because if we can get better sleep, we know that's probably going to outweigh the maybe the minimal negative effects from like something like a paracetamol. So those would be my recommendations for that question there. Were there any other questions?
At the moment.
Perfect. Okay. So envelope function. So the other thing we got to know here is pain is not a good indicator of recovery progress. By the way, going back to that question, if that person, sorry, I wasn't sure who it was, but if that person does want to chat more about that, just let me know after, and we can definitely talk further there. So pain is not a good indicator of the recovery progress. We spoke a bit before how pain is not always indicative of damage. When we start the rehab process, sometimes we have this kind of experience. It is very common, in fact, where our function actually improves. So we might get a little bit stronger. We might even get a little bit more mobile. We might be able to start integrating tasks that we couldn't before, but our pain might actually be the same. And that's actually okay in the first little while, because it means our tolerance to pain is actually going up. Even though the pain is still there, if we can see other functional improvements and see our ability to tolerate things go up, we're on the right path. I tell a lot of people that we sometimes just hit a tipping point. We've got to chip away, we've got to chip away, we've got to chip away until there's this tipping point, and all of a sudden that pain starts to subside. There's a great story James Clear uses in his book Atomic Habits, when he's talking about habits, but we can kind of take it into the pain side of things. We talk about a block of ice sitting in a 0-degree room, and that block of ice is a block of ice, and the room is going up every minute by 1 degree, and after 10 minutes up by 10 degrees, the block of ice is still perfect block of ice, hasn't started to melt, goes up to 15 degrees, still looking pretty good. It gets to 18 degrees, it just starts to change a little bit. Then every degree after that, it is a disproportionate response of melting that occurs. And that's a nice way to consider the process a little bit. We often will find it's not a hard slog all the way through. You put in that groundwork. We don't know the time frame, unfortunately, but you keep putting in the groundwork, you keep pushing through, you keep building your strength and movement and challenging things that you might be a little bit fearful of from a movement perspective, and there comes a time where things just start to turn. And again, another one of my favorite little graphics to show people, because it is sometimes hard to see that we're on the right path when the pain has been persistent, but we've also been consistent with the rehab strategies and the recovery strategies that have been recommended. So again, for people who are struggling through that process, it is a matter of just sticking with it, keep working, because you will hit a tipping point and things will get better. So then we'll come more into the rehab itself. So we got good rehab versus bad rehab. Good rehab, in my opinion, needs to be simple. It needs to be effective and practical. It needs to be goal-orientated. It needs to be person-focused. It needs to be challenging, and it needs to be progressive. We get a lot of people who come through and they've been given some kind of exercises, and they're either overcomplicated. They're not practical for the home environment. They're not in line with the person's goals at all. So they struggle to see like the purpose of doing them. So they might not engage with them that often. They're not challenging, or they start off challenging, but then there's no progression. So just like any fitness, if you keep doing the same thing all the time, at a certain point, you're not getting any fitter. It's kind of the same thing from a rehab perspective. At a certain point, if we're not challenging the system, we're just not going to evolve. And then there's not progressive as well. The other one is overcomplicated instructions. Sometimes people get all these kind of cues and things to focus on, and have to squeeze here and hold there. And the reality is, we're not going to remember that stuff. It's too complicated. So we want it to be simple. We want it to be effective. To me, the simpler a program is, the the better the long-term outcomes are. So this little graphic here, so I was meant to be earlier. Injuries occur when load is greater than capacity. So when the load on the body is greater than what the body is able to cope with, we get an injury. When the load is equal to or less than our current capacity, we call that rehab. And then when it comes to the prevention side of things, is when our capacity is greater than the load. And that's a really important one to consider as well, because as we go through rehab, the goal is that rehab should end at a certain point and turn into prevention. We always say in our clinic that we want you to be better than what you were before your injury, because then we know we're in that prevention state. If you were lifting, I don't know, 100 kilo deadlift, and that's what injured you, when you come back, we want you to be lifting 120 kilo deadlift, because that's now pushing into the prevention. We increase our capacity. It's greater than the loads the body needs to be prepared for. And that should always be the long-term goal. Okay, so keys to a successful rehab strategy for the patient. So from your perspective, you're a patient listening to this, or someone dealing with back pain. Your mindset always comes first. How we, going back to how we see the problem is the problem. It's also about making sure that we're being very proactive, that we're setting a positive mindset, that we're trying not to be too negative or down on ourselves. And that's not easy. I personally know that from my back pain. It's not easy when it's hard to see the end point. But it is up to us to take that positive mindset. Viktor Frankl, the famous Holocaust survivor, always said that between stimulus and response, there is our ability to choose, and I'm a big believer in that as well. We need to choose our mindset and choose what we, the thoughts that go through our head, and try to keep them positive and proactive. We need to remember that pain does not equal damage. Because through the process, you're going to have some ups and downs still through rehab. It's not a linear line of improvement. It goes up and down. But if we know that pain doesn't equal damage, it helps us manage those more challenging times of the recovery process. We want to be consistent through those ups and downs. So we accept that they're going to come, and just kind of keep working through it. Just like any challenge in life, there's going to be ups and downs, and we just got to kind of pop our head down and just work our way through it. It will come out well on the other side. We need to have a good understanding of pain and its complexity. So we spoke about that, and know that there are no quick fixes. It's easy. It is so easy in today's society to get caught up in this quick fix world. Just today there was something on my Instagram about some kind of thing that you laid on that helped neck pain and headache. And it had like 1 million testimonials and videos, and it's all, it says evidence-based, not evidence-based. There's 1 million quick fixes out there. There are 1 million doctors and practitioners who will also sell quick fixes, things like telling you it's pronated foot, or it's a tilted pelvis, or it's as soon as you hear like it's this one thing, then you're probably getting sold a little bit too. So it's important to keep in mind there are no quick fixes. It's a process, and if we're going to approach it like any other challenge or skill, if we put in an analogy of learning to play guitar, for example, there's no quick way to learn guitar. There's no amazing course. There's no nothing. I can tell you that because I've been playing for a while and I'm still rubbish. And I've bought all these things. There's no quick fix to any of this stuff. It's a process, and we got to take it on with a positive mindset, accept that there's ups and downs, and have some good understandings of what to expect along the way. So how to know if you're working with the right practitioner or doctor. I created this post, or I created this and turned it into a post recently, and completely coincidentally, there was actually another research article that kind of came out on all the key things to go for, to look for in a practitioner or in an approach to recovery, and it actually ticked like 6 or 7 of these. So I was pretty happy to see I was kind of on the mark there. But number 1, they spend the time to listen to you, your concerns and your goals. Number 2, they have a positive outlook. Number 3, they encourage you to do things that are important to you. Number 4, they communicate the problem and solution clearly in a way that makes sense to you. Number 5, they give practical, proactive advice. Number 6, they don't tell you to stop. And that's don't tell you to stop doing. They might modify things, or they might, if they do, last case, don't have to tell you to stop. It's only for a short period of time, but they don't have black or white rules about what you should or shouldn't be doing. They are, number 7, they are able to help you modify your daily tasks and exercise. Number 8, they create a long-term rehabilitation plan in line with your goals. And that's a big one, because I can tell you now, as a chiro and strength and conditioning coach, and I've spoken to many of my physio friends as well, we're better trained at the short-term stuff than we are at the long-term stuff. That's what we're trained for at uni. We're trained to get people out of pain, but beyond that is where the study really honestly lacks. So keep in mind that most people are not trained to help with the long-term side of things. So you want to look for people who know how to do that. Number 9, they are cautious prescribing medication injection or referring for imaging. So there's nothing wrong with some of this stuff in the right circumstances, but you want a practitioner or doctor who doesn't just do it willy-nilly. You want them to be cautious about it, methodical about it, thoughtful about it, and not just doing it for the sake of doing it because that's just what they do. And number 10, they don't talk about alignment, imbalances, subluxation. They don't talk about these kind of structural things. They might mention little things along the way, but that's not their diagnosis or what they're truly working towards. They should be giving you a much more broad advice, global-based approach, not saying it's a specific thing that only they can fix. I think number 11 is the same as another one there. Number 11, they spend the time to listen to you and your concerns and goals. That was number 1. So those are my 10 tips for knowing if you're working with the right practitioner or doctor. So I'm going to show you a couple of videos here. These are some of the exercises that we run through with people. This is Elise here. I think we were introducing this exercise maybe at that point. Sorry, Elise, I didn't tell you you're going to be in the presentation. But for people who struggle to bend from the spine, this is one of our options that we help people to get moving. So we give them a weight. We don't coach them or cue them. We basically just ask them just to touch the ball down between their toes or on the outside of their foot. We go into other ranges like rotating from left to right, which I think is coming up now. And we just get them to start exploring that motion a little bit. It's not structured. It's not over coached or cued. It's just simple, straightforward stuff. This is a great back extension exercise that I love to give out. So we're just on a ball and we're starting to load up these lower erector muscles through here. Really great one because it's an area that many people don't address. We often focus on glutes and core and things like that, but not so much on those lower back muscles. And we progress and regress these according to the person and their tolerance level. So this is another one of my favorite, which are they're called chops and lifts. This is actually a lift where we're going from down to up in a rotational way. So these are really, really functional. They allow the person to develop some good strength resilience in these rotational kind of ways. And so again, one of my other favorite little exercises there. Again, we've got, again, some rotational planks. These guys here, really good because they hit the side body and the core, and now we're trying to control the hips and the spine at the same time. They're hard to do, but they're a little bit fun as we work our way through them. But all these exercises, one of the commonalities is that we don't have to coach or cue them too much. Minimal coaching is really, really essential. We need to give enough so we know what we're doing, but a lot of these exercises are nice and simple, so we're not going to really mess them up too much. So another one here, which is a stir the pot. So now we start to introduce this much more advanced core exercise. See Grace doing a really good job holding everything tight through there. But we start to introduce a little bit of instability into the system as well, so it can start to respond and react to the changes in movement of the ball. And we've got a whole lot of different drills to challenge that as well. So all these exercises, whenever we give them out, we have progressions of them, we have regressions of them, and all we're aiming to do is find a starting point to help people just begin the process of that kind of progressive overload and building that bit of resilience. All right, so I'm going to close this over here. What I might do is I might open for some Q&A, and then we'll get moving after that. So let me come back here. Are there any questions? Anyone have any questions about anything we just ran through? I know there was a lot we just spoke about. Does anybody have any specifics? Perfect. I covered every possible aspect. All right. So cool. All right. So what we're going to do now, feel free again, if you have questions, just yell them out or type them in the box there. So what we're going to do now is we are going to kind of get moving. So if everyone's got a few meters square space, nothing exciting going on really, but we're going to run through a little bit of a movement flow to help kind of get the lower back moving. I'm going to email a little program to you again about a few days after the presentation's finished. So you'll have a lot of this stuff at home. But if you want to find a little space on the ground, I'm going to bring you over. I'm in my kids' play area, so there's a few toys around.
Thanks, Dan. I've got to go, but chat to you soon.
Cool. Good to see you, Sean.
Thanks, buddy.
All right, so we're going to keep everything really, really simple. Get this elephant out the way. We're going to actually start with some breathing. So this is really easy stuff. We're actually going to find a comfortable position. We could be on our stomach or on our back or whatever position is comfortable. And we're going to start with some diaphragmatic breathing. So I'm actually going to lay on my back. I'm going to show you guys what we're going to do. I'm going to start with my hands on our belly. And we're going to start by just focusing on 10 breaths. We're going to aim to lift our hands up with our belly. So we don't want to see the shoulders shrug up as we breathe. We're going to breathe in our nose, out through our mouth, and we should feel our hands gently raise and fall. When we breathe out, it's just a relaxation. It's not a proper exhale. It's just a gentle breath out. So we go for 10 of those. So nice and slow, deep breathing in. Just going to calm the system, any tight muscles, just using our breath to relax them. Okay, from here, we're going to go into some windscreen wipers. So we're going to pop our hands down by our sides, just like that, up a bit. We're going to lock our shoulders and hands to the ground, and we're just going to start with some gentle mobilizations left and right. You might get a few little clicks and pops. If you can't get all the way down without letting the shoulder come off, if you let it come off for just a little bit, that's perfectly fine. But we're just going to rotate. We'll do 10 all up, about 5 per side. If you've got pain, know that it's okay, assuming it's not more than 5 or 6 out of 10. If it's just a little bit of stiffness and tightness, work through it a little bit. Perfect. From here, what we're going to do is we're going to finish up on one of our sides. We're going to bring one hand on top of the other. In fact, I'll do it this way here. So we're going to finish up on our side. And now we're going to do some book openers. So we're just going to move. Our head's going to come with our hand, keeping our knees locked down to the ground. And we're going to again do 5 or 6 per side. When we've finished on that side, we can roll our knees to the other side and do the same thing. Again, all within your comfort zone, but be okay with a little bit of discomfort. Okay. Still staying on our back, we're going to go into a dead bug. So knees up in the air, hands up in the air. We're going to take opposite arm, opposite leg, and we're going to get nice and long, and we're just going to alternate from side to side. And what we're looking for here is to keep nice and tight through the core. We want to kind of lock our back onto the ground so it doesn't arch away. And we're just alternating through this pattern here. And we'll go for 10 of these alternating, so it'll be 5 per side. If you're struggling with that, if it does cause pain, you can reduce the range of motion by just keeping a bent knee or a bent leg there. Or alternatively, you can have feet on the ground and do kind of one arm, one leg at the same time. You've got a few options there. I think I've got a question there. Perfect. All right, so from there, we're going to come up onto our knees. And we're going to do some kneeling hinges. So we're just sitting back through here. We're going to move up and down through this range. This is going to help us get some activation through the glutes so we can lock the hips out of the top and move through that nice hinge progression. We're going to run through about 10 of those. Excellent. Okay, so now we're working through the hips a little bit more. We're going to go into something called a shin box here. Foot and shin in line with each other, just like that. Nice and tall. We're going to pop our hands behind us and we're going to move from side to side. So use your hands to support you a little bit. You can move your legs around if you're struggling to move the legs and the hips in that direction. You can do even just little ones, just side to side, just like that is fine. And then if you want to challenge yourself a little bit more, you can pop your hands out in front of you and you can start to move without that support. I'm not so good at that, so I'm going to use the support. If you're really good, you can do them with arms up overhead. I'm not going to make a fool of myself doing that. If you can do it, very impressive. Perfect. So keep going, a couple more there. Great. So now what we're going to do is we're just going to get onto our hands and knees quite far apart, kind of like a squat width there. And we're just going to do some back and forward rocking. So we should feel a nice stretch through the groin area. We're just going to rock back and forth. Great way to get the hips moving. You can play around with the hip width. You can do circles at the bottom or U's at the bottom there as well, but up and down, back and forth. Perfect. From here, what we're going to do is we're going to rock, do the same thing, and we're going to walk our way up into the bottom of the squat and then back down. Just like that. Back down. You can stand up from the squat if you want as well. So you can come in through here and stand up. we can start to explore that squat pattern. Excellent. Now, staying back on our hands and knees, we can actually start to run through some bird dogs. So the way I like to actually do these is opposite arm, opposite leg, get really long. We're going to do the same side. So we're going to do 5 repetitions. And on the 6 repetitions, we're going to do 5 just like this. And on the 6th rep, we're going to hold for 10 seconds, holding in that position there. And the other side when you're ready. So 5 repetitions, hand to knee, get really long. Nice big hold at the end. Back down. And the final thing we're going to run through is a little bit of core stuff. So we're going to now go from in a plank position on our toes if we can. If you can't, on our knees is perfectly fine. And we're going to go from plank and rotate into a side plank. So challenging this one. Rotate into a side plank. Don't overthink it. Just slow movement, slow control. If you struggle, you can do it on your knees. So in this position here, you can still kind of roll yourself into a side plank on your knees. Perfect. So you have just run through one of my favorite little movement flows that we like to give out for people with lower back pain. I've got my heart rate going up a little bit as well. So give me some feedback. How did everybody feel doing that? Were there any questions about any of those movements or those exercises? Everyone's still out of breath? Any feedback? Anybody hearing me on this side? Perfect. Love it. Great. Excellent. Okay. So I'm gonna be sending you a fair bit of this stuff soon. Suggestion for stretches. So again, it is specific. Like I think it depends what you want to stretch, to be honest. I know that's a bit of a sound maybe like a bit of a cop-out, but there's no magic stretch. Those particular movements, you can hold them in a stretch if you'd like to. So the windscreen wiper, which is the one we lay on our back with our hands down, you can hold those knees off to the side and just use it as a general stretch there. The thoracic book openers, which we did as well, which was when we were laying on our side kind of doing these ones, you can hold the stretch there as well. The reason I don't hold the stretch with a lot of this stuff is I just want to get people moving. I want them to not think a huge amount about what they're doing, just start to engage in different ways of movement, basically. Simple as that. So I am a big fan of yoga. So if kind of those long static stretches are the thing that helps you with your back, without a doubt, hop into some yoga. I think it's fantastic. It's something that I use most nights of the week, and something that I'm a big advocate for. So your standard yoga stretches are my favorite. Down dogs, things along those lines for sure. Perfect. Any other questions at all? Perfect. Okay. So hopefully through tonight, I've given you a good amount of feedback, a good amount of information. This is all the stuff that I tell our patients, and the stuff I'd like to tell my patients. Sometimes time's not right for them to hear it all the time, but for the most part, this is all the big key things to know. It's all backed by the science, backed by the evidence. Sorry, Pat, would you say those static movements are the baseline for recovery, or do we need to include weight training as well? Yeah, I'd say you definitely need to. You need a mix. There's no one or the other. There's no stretching is the way, or strength is the way. You probably need a range of different things. So I would generally, so our program, which we'll talk about in a second, includes a bit of everything. So strength is probably one of the biggest foundational things that you need, and a progressive strength program. Stretching and mobility will often use just to reduce pain in the short term. It's really effective for that. But building strength actually changes the quality of our tissues, and strength training ultimately makes us that little bit more resilient to the daily forces that we put our body through on a day-to-day basis. So if we work in a in a trade or something quite physical, if we can build our strength up more than what we need, so if we build our capacity more than the load, that's our prevention, like we said, like we ran through one of those slides. So strength helps improve our tolerance to load. So strength, without a doubt, is going to be something that's really important there. Perfect. Any other questions before we move on? Excellent. Okay, well, feel free to shout out if you need. But hopefully, I got your heart rate up. I've got a little bit of a sweat going, embarrassingly, but there's a little bit of motion. You'll get it all shortly as well. So I'll just come back through here. So all of this kind of stuff, obviously, it's important. We've got to have a strong evidence base. We've got to be working with clinicians and doctors who have a good, strong evidence ethic to what they prescribe and the words that they use and how they help people with back pain. This is a little bit about what we do for our rehab strategy. So I mentioned before, we have our success strategy. So this is something that's sent to all of our new clients, and we run through their diagnosis, their goals, key findings, rehab strategy. So we'll write out their different phases and general notes, and we've got some general tips and tricks and things like, well, not tricks, but general tips around how do we enhance or optimize our recovery process as well. So it's all through there. And we've just rolled out our recent 16-week, what we call our Back to Your Best program, which is a lower back pain program specifically designed for people with chronic back pain. So the program, 16 weeks, you get to do your training with us in the clinic. So we've got Elise, who's our coach, who runs through it all, and we write you a full program in line with whatever your goals are. You get your weekly treatments and check-ins, so that makes sure that we address any hiccups. We keep you supported through the process. Uniquely for the program, we actually created an educational component as well. So you actually will get some kind of like little weekly series of things to consider for the week around pain and recovery and strength and all of those kind of things, a lot of tips and things like that, and then lots of recovery as well. So that's kind of how we've best been able to bring together all of the guidelines and evidence basically into one program. And where I came from this when I was creating it was just what was the thing that I wish I was given when I was going through my back pain recovery. So with all of that said, it's all private health rebatable. If you're DVA or if you're a veteran, it's DVA is fine with it as well, which is great. It's $149 inclusive. If anyone is interested in that program, just message me after the event, after the webinar, and we can touch base on that as well and can make sure it's right for you there as well. And we've just got a little incentive that anyone who signs up in the next couple of days will save 2 weeks off the program. So it's all there. It is limited to only a couple of people. But if you are someone who wants that, just move through this whole process a lot quicker. That's what the program is ultimately made from. And it is in line with all the current evidence and guidelines. So, you're getting the best program you can. But my final message here is basically keep in mind your body is adaptable and resilient, and regardless of your diagnosis, you can change, adapt, and regain your physical abilities. So we've had people who've had tremendous amount of pain who've gone back to run marathons. We've had people who've PB'd in powerlifting and Olympic lifting competition, who've returned to amateur and professional football. From places that, if you'd seen them when we had seen them, you just wouldn't believe, they were going to get back to that level. And that's not us tooting our own horn, me tooting my own horn here or anything like that. It's just the power of the body and how adaptable, resilient it is. So regardless of the image, the diagnosis, or whatever it might be, keep that in mind, because it is what our bodies were designed to do, is to adapt. And it's irrefutable about how adaptable it actually is. Pain does not equal damage. We touched on that a couple times. The other thing is, don't sweat the small stuff. Focus on the big rocks. So focusing on health, sleep, all those kind of things, focusing on just being consistent with your rehab and things along those lines. Focus on those things, the little things like feeling a little bit out of alignment, or is one leg a little bit longer than the other, or just little things like that. We just don't need to worry about them. We can feel them. It's not to discount feeling them, but they generally have zero. They almost always have nothing to do with the recovery process at all. We just got to focus on the big key things: being consistent, keeping a positive mindset. Recovery is not linear. We spoke about that as well. It fluctuates. So measure your improvement initially by your functional improvements, not your pain. So pain might stick around for a little while, but at a certain point you'll have that tipping point, and that's when your function and strength has kind of exceeded a certain point, and your pain will start to subside from there. Recovery takes time. Make sure you have clarity in your recovery path. That's another big one, I think. People don't have clarity. What's coming up next? What are we working towards? What is my ultimate goal? What do I want out of all of it? If we can figure out and specifically say, in X amount of time, I want to be back running, 40 Ks a week, or I want to be back playing touch football, I want to be back doing X, Y, or Z. It could be playing with your kids, your grandkids. It could be just getting back to work without any pain. But know exactly what that long-term outcome is, because it's much, much easier to go through a process when you're anchored onto a specific goal. Again, going back to my guitar analogy, for me to say I want to be a great guitarist means nothing. But if it was, I want to, be able to play songs like Eric Clapton and play this song, that song, and that song, then I can anchor specifically onto that. There's an achievement that I can actually get to with that. So be specific with what you want and where you'd like to be after your recovery. And finally, you've got it. So if you are dealing with back pain, hopefully you've got enough here tonight to maybe inspire you a little bit to carry on the tough fight that it is. If you are working with somebody and you don't think that they're maybe applying the evidence, the guidelines, the things we spoke about with a good clinician as well as they should be, maybe it's time to move on. But it is important that you as an individual have a good base understanding of all of this, because at the end of the day, that's going to help you make better decisions. It's going to help you through the recovery process really well. So that's 9 on the dot. So we're pretty good time-wise tonight, which is unusual for me. But I hope you've got something out of this. I really do. I'll send out a recording. Fingers crossed it's recorded. But I'll send that out if it has. And you'll get a few other little things in an email coming in the next couple of days. And feel free, if you've got somebody who's dealing with pain, who you think would benefit from this, feel free to share the recordings if it comes through, or at least you'll get the slides. You can share that with them. And if you're not a current patient of ours and you want to work towards a better back, obviously you know where to reach out to us as well. So I hope you've all got a bit of good information out of this tonight. I'll leave it again. If there's any other questions, just click them in the chat or unmute yourself and have a chat to me. But thank you so much for your time. It's something I've wanted to do for a long time, is run one of these, and it'll be a few more, I'm sure, coming up over the next year or so as well. Perfect. There are lots of familiar names in there, which is great. Good to see. I didn't know who was actually coming on the call. Perfect. Excellent, guys. Well, thanks so much for your time. If there's any other questions, you can always email me and I'll always get back to you. But otherwise, have a great night and thanks for spending your time on this. See you.